Hello, my name is Danielle Soranno, and I'm a pediatric nephrologist at Children's Hospital Colorado. There's been a lot of important data about acute kidney injury in recent years. Until fairly recently, most providers didn't worry too much about acute kidney injury because we really thought it was just acute and that our patients' kidneys would recover and be fine. Now, we know that acute kidney injury worsens both short-term and long-term outcomes for our pediatric patients. We know that in the intensive care units, acute kidney injury is linked to increased mortality and prolonged hospital length of stay. In this study, we wanted to investigate whether non-ICU care was similarly impacted by acute kidney injury. That is to say, is acute kidney injury a big deal for common pediatric hospital admissions?
I'm Justin Searns, a pediatric infectious disease specialist and hospitalist at Children's Colorado. We use the Pediatric Health Information System, or PHYS, database to examine inpatient hospitalizations from 2009 through 2013 at 34 participating pediatric hospitals throughout the United States. The PHYS database includes clinical and resource utilization data from participating children's hospitals around the country, allowing researchers to access de-identified administrative data based on hospital billing codes.
I'm Katja Gist, a pediatric cardiac intensivist at Children's. By using the PHYS database, we were able to harness a large amount of data to compare outcomes of common pediatric illnesses to see if the development of acute kidney injury had an effect on their hospital course. In the range from 2009 through 2013, there were over 3 million pediatric admissions within the database. We excluded patients from the study if they were hospitalized in the neonatal intensive care unit, if they were admitted longer than a month, if they died during their hospitalization, if they left against medical advice, or if they were transferred to another facility.
Next, we grouped patients into categories based on their primary diagnosis: acquired cardiac conditions, acute respiratory illness, common surgical conditions, cystic fibrosis, gastrointestinal illness, cancer, or infection. We then used hospital billing codes to review all the diagnoses patients were assigned during their hospital stay. Using the ICD-9 code for acute kidney injury, we were able to identify which patients were diagnosed with acute kidney injury during their hospital stay.
Exposure to nephrotoxic medications is one of the leading causes of acute kidney injury in pediatric patients. The PHYS data also allowed us to examine exposure to nephrotoxic medications during these hospitalizations. Overall, the rate for significant nephrotoxic medication exposure was 6.8%, and not surprisingly, this exposure was associated with increased rates of acute kidney injury. Children hospitalized on the wards without nephrotoxic exposure had a 6.4% rate of acute kidney injury compared to 20.7% if they were exposed. Children hospitalized in the intensive care unit without nephrotoxic exposure had a 10.5% rate of acute kidney injury compared to 34% if they were exposed. We were also able to investigate the types of hospital admissions that commonly expose pediatric patients to nephrotoxic exposures. For example, 64% of patients with cystic fibrosis had a high nephrotoxic exposure during their hospitalization.
We then performed statistical analyses of the data based on the year of hospital admission, patient age, primary diagnostic category, and the level of hospitalization. The overall median length of stay for all admissions was 2 days. Both the level of care, wards versus intensive care, and the presence of acute kidney injury impacted hospital length of stay. The median stay for wards patients without acute kidney injury was 2 days compared to 5 days for children with acute kidney injury. In the intensive care unit, the median stay without acute kidney injury was 4 days, and that increased to 12 days for critically ill children with acute kidney injury.
So one of the take-home messages for us from this study was that children hospitalized on the wards who develop acute kidney injury had either longer or similar length of stay as critically ill children in the intensive care unit without kidney injury. Obviously, there are some important limitations anytime you are working with administrative billing databases like PHYS. In particular, we don't have access to clinical or lab findings to confirm presence or absence of acute kidney injury for all patients. We only have billing data to go on. Despite that limitation, though, we really think our findings help to hammer home the important role that acute kidney injury has on common pediatric hospitalizations.
The data also confirmed that nephrotoxic exposure increased the risk for developing acute kidney injury. Here at Children's Hospital Colorado, we have implemented the nephrotoxic injury negated by just-in-time action, also known as the NINJA program, throughout all units, including the wards, pediatric ICU, cardiac ICU, and neonatal ICU. The NINJA program has been shown to reduce the rates of nephrotoxic exposures during hospitalizations, as well as reduce the rates of hospital-acquired acute kidney injury.
Thank you for taking the time today to hear about our research. We really believe it is important to work across disciplines in order to tackle common problems like acute kidney injury, and hopefully this study will help bring awareness on the important role we play as hospital providers in both mitigating the risk for acute kidney injury and recognizing its clinical impact and importance.
We'd like to thank our co-authors, Dr. Jim Todd, John Brinton, Casey Packett, and Megan Burkholtz for all their dedication and effort on the project.
This work was performed by the Pediatric Kidney Injury and Disease Stewardship Program and was supported by the Department of Pediatrics and the Research Institute at Children's Hospital Colorado.